we need to be following our patients. And how long do we follow our patients? Dr. Borson talked about how he follows his patients 20 plus years, and that's actually what I think it should be. We should be following our patients for life. So here is my immediate post-op protocols, just because I know there's some therapists in the room that always have these questions. And again, this is mine. This is not everybody else's therapy, but I'll tell you why I do it. So when do you resume compression? When do you resume MLD? MLD should be, every time we take the patient to the OR, we should be watching that ICG lymphogram just meticulously. We should be seeing how it's functioning. What's the quality of the lymphatic vessel? We need to see what the ancillary outputs are. Like those images that Dr. Chang showed where you had that medial vessel that was going on in the axilla. I take a drawing of that and I send it to the therapist and say, focus on that segment. When you do your MLD, that's where, and I tell the patients and the family member that too. So you know where the function is, so why don't you use it? So that's the benefit. So when do I resume MLD compression on a bypass patient? I think 2 weeks, mainly because these vessels are really fragile and you don't want to be pulling a garment on and ripping what you've just fixed, if you fixed anything. Remote MLD immediately, so I say about a hand's width away from where I operated, because I operate through tiny little 1 centimeter incisions through little tunnels. And just because we have better equipment, better technology, so I can see it better. Remote immediately, so away from the surgery sites. Entire limb, about 2 weeks, same thing, concept, healing. Lymph node transfers, I wait 3 months for resuming compression. Why? Because you put a flap there, like I said, that's got venous outflow, artery vein in, you compress it, you're going to kill the flap. So why would you do that? I know there are some other centers in the United States that put them in immediate compression after a lymph node transfer, and those are the same patients I see, the dead flap that I showed you before. So when did we resume MLD? Same concept. I wait remotely away from the flap. Go ahead and go to town on MLD. And then near the flap, I say again, hands width away from my incisions, because that's where my pocket is, hopefully not bigger. And then that's when we get back to entire limb. The question is, which direction do you go? Do you go towards the flap? Do you go proximal? So that's a tough one. And I think hopefully Dr. Mingwei Cheng will show his images on that later as far as that. And liposuction, obviously immediate compression on the table. Then when I resume MLD for the liposuction patient, I'd say 2 months. But again, it's really, really important to understand that MLD is not MLD in all hands. And for those therapists in the room, you know what I mean by that. We're not petting the cat for liposuction patients. Okay, if you pet the cat for liposuction patients, it's not going to work. So these have to be more of edema techniques. When do we resume exercise? The core principle is skincare, immediate, within reason. I mean, if I've got a professional athlete, which I have had, I tell them to hold off, or CrossFit patients. And then when do you resume all these adjuncts? Well, I just say it follows the above. If it's an adjunct for compression, if it's an adjunct for MLD, then we follow those options. So that's my immediate post-op. What are my long-term post-op protocols? Here's a picture of me when I was working with Dr. Chang. And again, these, I don't know why I put this picture in. Well, yeah, because he left me. And since he moved so far away, all of his patients became my patients. And then another, Roman Scracchi, left us again, and then all of his patients became my patients. And then, so now I'm ridiculously too busy. So then I left too, and I said, go away. No. But no, I just moved from Houston to Dallas, so it was too close. So all of their patients still come to me. So the real thing is why? Why did I share this? Because it's important. These patients should be followed for life. It's a lifelong disease. So that's really important. Don't do surgery and say, good luck to you. I cured you. I hate that when I have a patient come in and say, oh, my plastic surgeon said I cured you. Each visit here, Dr. Borson showed a great image, and I've kind of utilized some of those things, and this is my post-op protocol visits, just an image of it. Other thing, everything in your visit, you should have history, physical, quality of life studies, photo documentation. Those are all important. Measurements are very important. Again, both extremities as they gain and lose weight. Also, in another comments, perimetry is one option. The water displacement's another option. Bioimpedance, I'm not going to touch on that today. And imaging. So now I'm going to get to the imaging. What do we do? So a lot of it has to do with what do we do preoperatively. So a lot of guys, Dr. Nelligan went a lot through imaging, but what is the role of imaging? So preoperatively, it makes sense, right? You're staging the patient, you're getting diagnosis of lymphedema, you're defining your anatomy, you're determining you want to put a proximal distal. It helps with surgical decision making. Also, it's important for collecting the data because these are procedures which we haven't proven extreme long-term results on. We've shown short-term, long-term results, kind of, and but we really need to prove that we're actually making a difference. Post-operative, that's a little more difficult. You can still stage. You think about objective outcomes for research protocols, and you can compare the data points to the preoperative. But the most important thing from my question is, will imaging post-operatively help you? Will it change your management on this patient? And most of the times, it depends on how the patient responded to our intervention. And that's really important in my eyes. And especially me transferring my practice, I found that I didn't want to harm the patients more just for data collection. So I'm going to talk about imaging, and this is honestly my most important device in my clinic. And we haven't even touched base on this yet. So ultrasound is, again, the most valuable tool. Why is it valuable? I'm going to tell you why. It's non-invasive. It's free. Not free. I bought it. But there's no radiation and no injections, no pain. And a lot of patients will come to you and say, well, I don't want a lymphoscintigraphy because it hurts, right? Other things, it's simple, efficient, and really quick to do. While I'm examining the patient, while I'm talking to the patient, while I'm counseling the patient, I'm doing imaging, I'm getting data on the patient. It's easy to use, easy to compare. I always compare contralateral side because, yes, we've got some great pictures of MRL showing you the edema and all this other stuff, but more importantly, this is extremely educational for the patient. I find this so useful to sit down with a consultation and say, this patient came in saying, MLD doesn't work, compression doesn't work. Well, let me show you why it's not working, and we got to change our algorithm. We have to adjust our CDT for you as a patient. And like Dr. Nelligan said, his is a better conversion ratio than mine, but I did an analysis. I only take 20% of my patients to the OR. Why? Because I'm taking all comers, and there are a lot of patients that are definitely not surgical candidates, but we still see them. So this is educational for the patient. Here on the one side you have affected arm, unaffected arm. And you see just A measurement is fat content, B measurement is skin thickness. Dr. Mahar did a great study in the past about skin thickness in response to surgery, and instead of biopsying them, I have those patients in my practice. They hate that biopsy scar, but doing this is real simple, and I've been following these patients long term. And again, this is really important. It's not just a skin disease. Yes, skin is the first representation of lymphedema, but you've got muscle changes. You see that difference in muscle changes. You see the difference in the fascia. I show that picture of the deep fascia thickening. You got the adipose. This is where the liposuction plays a role, as opposed to adipose consolidated hypertrophy. Skin thickness, like I said, it's not only a thickness. Here, this patient doubled in size from 0.2 to 0.4, but also quality. You see the basement membrane fracturing on some of these patients. That's a good sign in my practice on how controlled is this patient. If their basement membrane's all fractured, these are patients that are getting cellulitis, getting infections. Those are patients that we have to control them better before we even think about surgery on them. And then, of course, there's the fluid. The lymphatic fluid is patients that are completely not controlled. So, again, I like to even use, like we use ICG-directed MLD to find the anatomy. I use ultrasound-directed MLD on the patients. So you can see here, this is affected, unaffected side, just to show you the difference in the patient. You see that affected side has, in that A section, a lot of fluid. You can see that the skin thickness is twice as thick again. But what I do is I sit there with them and I show them what skin stretch techniques do. And it's really important for a therapist in the room to think about this. If your skin is a half a centimeter thick, does petting the cat work? And remember, where are your lymphatic vessels? And you gotta remember where your collectors are. So that's really something. I run into a lot of frustration. My job is to educate, and I hope that I go in and educate people that are some people would say, though, they're adamantly against deep techniques, so you're going to damage the lymphatic vessels. And not in certain cases. You have to really know your identification. So ultrasound is so critical because it just gives me x-ray vision. Other things are edema techniques in this patient. Look, I did edema techniques on him, and we got that fluid out, and this is what I want to see. That, like Dr. Borson showed, you don't want pitting. That picture on the right is the perfect, if they had a lot of consolidated hypertrophy of like fat, that would be a liposuction candidate after they've been maximized. So that's ultrasound. I think it's critical, and it's essential to a practice. And again, it's great for patient education. And of course, we went into ICU. I'm going to fly through the rest of this because it's really been covered multiple times. But this has been the big leap forward for lymphatic surgery, is being able to see it. What's really important is I standardize, and I think everybody should standardize how you do it. Yes, you inject, you watch what's going on, but then you have to look at the clock, at the time, because like Dr. Chang said, if you walk away and come back, the whole arm is white, and then you didn't catch anything. And so it's really important. I can make it look like anything I want depending on when I took the picture. So how are you going to stage this patient? So injection sites, dosing is always critical, and so it should be standardized. Imaging, timing is standardized, and I think it's really important to stage these patients. So these are pre and post-op images. I'm going to jump through that one just to go. This is the classic picture of traditional ICG staging. And then a lot of things that a lot of old partners like Dave Chang and Roman Skrak and Hugh Swami really worked on. A lot of their data we put together, and we said, okay, well, that imaging is great and it's a great picture. It's kind of like Starry Night. You're looking at just describing how much splash you have, but we wanted to talk about function. So this is how we started dividing up into function. So we published this modified ICG staging, and it kind of shows you the difference. And it's really important for those that are doing these procedures is you have to maximize these patients, because if they're not controlled, you're not going to get anything. You're going to get a stage 5 because they're just swollen, and there's just so much traffic that you're not going to get any imaging. Don't ever image a lymphoscintigraphy until they're controlled, because it's a waste of a study. So imaging. So again, this is just a slide. We did this huge study of a couple hundred patients where we compared 2 devices out there, and I just like to think of it as some devices have better penetrance. I know that we're going to talk more about like building devices of your own, but there's a huge difference between devices. And in my practice, I believe we want to use the best equipment possible to get the best outcomes. And if you are overexposing, like some devices out there where it's like if you take a picture and you turn the flash on 1,000,000, you're not going to see anything, right? So that's really important. There's some other devices that other people are working on that are actually even better penetrance, better resolution, but we don't have access to those clinically yet, but I hope so soon. So again, post-operative role. What's the role of ICG in these patients? So we actually, when we were doing it, we started doing ICG right away, like a month after. There's this whole study, and we didn't find any difference in the patients. And I think a lot of it is, like was said before, it's patience. So I started doing the ICG later. Letting time evolve, letting the patient improve. So here's a patient, pre-op ICG, stage 2, post-op, lymphovenous, minimally invasive lymphovenous bypass, and this is her result. And again, timing is critical. I mean, I could have taken that first picture just at 1 minute, and it would have looked just like the bottom picture, but it's important to balance your outcomes and results and be honest about it. So this patient had multiple episodes of cellulitis, bypassed her clinical response, but again, it was mentioned small subset of patients. It's not for everybody, and that has to do with that one picture that I was showing previously of what the lymphatic vessel looks like. If it's peristalsing, or if it's fibrosed, if it's a lead pipe, or if it's just a clotted lead pipe, you're going to determine whether or not it really works. So other things is identify new targets. After a bypass procedure, here you go. You see her dermal backflow improved, and then it's hard. This one doesn't show up, but she developed a new target. Why? Because we were offloading her, and that previous target was probably just too impaired to show up in the first imaging. So that's something that I didn't believe in initially. I thought you had only one shot at doing this right. But now in some patients, if they have a focal deficit, I will go back and do another ICG on them just to see what's going on. We talked about the pain. There's multiple ways to dilute the medication to minimize pain. So other things is documenting function. Function is really important. For some patients, I do it in selected patients that have trouble spots, or I go back for surgery for other reasons. That's when I do it. Sometimes if the patient is doing well, do I need to do another ICG? And we did that study before. We showed no difference. But now that I follow my patients longer term, did that a little later, I've noticed an actual 1-stage improvement in our ICG function with a functional lymphatic transfer. Or something. So here's one when we're doing revision. This is her injecting into her web spaces. You see it lighting up. You saw we injected proximal and distal of the flap, and we saw the lymphatic, the ICG merging towards the flap, so it's acting as that sponge. And then we saw it go into the flap when we took the skin paddle off, so you can see it. And then you saw the lymph nodes light up, and that was my happy sign. Okay. So is there risk? I threw the slide in. This is nothing. This is because it was mentioned. Okay. So I grabbed this slide from one of my other talks, but this is a patient that had a trauma to her knee, and she had lymphedema of her leg. And this is an anatomic disruption, yet she went to a facility that did a 8-centimeter incision without the proper equipment and didn't bypass up here. Who realizes that anatomically doesn't make sense? And then, of course, she presents to me with iatrogenic lymphedema from a lymphovenous bypass. So this is a problem. Yes, there is a risk for this surgery, so we got to be very careful that we're doing it right and we're selecting our outcomes appropriately. So we don't want that. So lymphoscintigraphy, again, the gold standard. It should be standardized, again, as far as where you're injecting, how much you're injecting, timing. I really do serial images, so you do an immediate 10 minutes, you do a 1 hour, I do a 2-hour flow study, because this is what Dr. Ricardo talked about, is measuring the deep lymphatics as functional, as opposed to MRL, that's a snapshot in the patient. It doesn't show flow. So your timed flow is really important. I've actually converted to Lymphoseek exclusively now because I think it's a smaller molecule, it hurts less. So that's something that's really revolutionized my patient's experience. Instead of screaming and yelling, they're just like, oh, it hurts a little bit. So also with the lymphoscintigraphy, we add SPECT CT scan. I think this is, again, critical, like I showed in the other presentation of, you can map these patients, their functional lymphatic and lymph nodes before surgery, and you can know where it's safe and not safe. Post-op picture, here she is, functional lymphatics, lymph node transfer, SPECT scan, showing exactly where it is. It's important. Pre-op here, functional lymphatic transfer. It's really important. Again, patience is important. When do you do lymphoscintigraphy? Lymphoscintigraphy I normally do about over a year out, because it's like planting a seed and waiting for a full-size tree to come. And that's why you have to just wait. When we started doing lymphoscintigraphies at 3 to 6 months, because I was trying to write a paper on it, you know, it's just like the resonant problem is you don't capture exactly what's happening. And you see from all the speakers here that at 1 year, they're doing better. Then also at 2 years, 3 years, this is actually, there's still continued improvement. That's something that's really important and actually great and rewarding. Here it again, functional. So again, wait for a year at least before you do post-op imaging. And the question you always have to ask is, does it change your management? If my patient's doing great, do I get a functional study on them? No, this is an invasive study. So DEXA scan is another one. I'm a big fan of DEXA scan. I know it's an ancient technology, just like lymphoscintigraphy, but it also gives you segmental options. And we think of it for bone scans, but I think of it for adipose, for muscle, for segmental, for fibrosis. You break that down, and we're lucky. I think Dr. Kilbreth's here. She's going to talk about her stuff. But this is one of her charts. Basically, it shows that it's not always a fat problem. Yes, the patients do have some fat problems, but there are other patients that, like we saw in the ultrasound, that has more fibrosis, and that's those hand and feet. That's why you can't liposuction the hand and feet, because they're just dense fibrosis. You can't suck that out. So what are the post-operative roles, outcome studies? Since it's a DEXA, it's really quick. If I'm doing lymphoscintigraphy, they just jump on the DEXA scan. It's minimally invasive. MR, it was gone into a length, so I'm not going to cover this at length, but it's grown quite a bit. I honestly haven't figured out I see the preoperative role. I haven't seen the postoperative role in my practice, so I'm still trying to figure that out, and hopefully Dr. Nguyen can help me with that. Other imaging, venograms are really important in patients that have stenosis, so I always think of those. So my postoperative follow-up is, again, this is a lifelong problem, so we have to continue following our patients, get objective data, all of those. And imaging, it's useful for documenting our outcomes for research purposes, and ultrasound is extremely valuable. And the most thing is, outside of research studies, you have to ask yourself, if you're going to do this, you better make sure it's going to change your management on the patient. Okay, thank you.